Well, hey there, y'all. Just a quick reminder, this podcast's for fun and information only. It ain't medical advice, and the views are ours, not our employers.
Hey everyone, welcome back. It's What the Health with Brian and Nessa. Just to recap, we're two physicians who just catch up over conversations. Sometimes we chat about random things or things we've read. So I'm Brian Boss. I'm an internal medicine and pediatric hospitalist in Colorado. And with me is my good friend and colleague, Dr. Nessa Meshkati, who is not in Colorado.
No, I'm in Humboldt County right now. Hi,
Awesome.
everyone.
Yeah, where are you now? Catch us up. What's new?
I've been in my camper van Juno since Tuesday. Today's Friday. So I
Awesome.
maybe came like 700 miles north, and I'm in Trinidad, California. It is so beautiful, and my cells are all restored.
I love it. And this is a semi-annual, an annual trip?
Twice a year in spring and fall, I journey up this way because I'm obsessed with redwoods.
I love it. I love it. So to catch people up, you and I both had rounding stretches. You did what, 5 days?
Mm-hmm.
And I
5
think I was
days.
on for 9. One of the things that kind of always continues to strike me is when we finish these stretches, it just feels like there's a lot of life to catch up with.
To me, it feels like the light shining through the clouds. Like
Right?
time, because, as a contract employee, or I'm sorry, contract worker, no longer a wage worker,
Right.
it's just like a different world. Your schedule
Totally.
opens up and you can create your, days off. And that has been so important to me.
Right. Yeah. Because your time off is your time off. There's nothing for you. You have no obligations, right?
I mean, I have a lot of projects. I would say this venture up north is one of my non-medical projects.
Right, right. But you have no clinical, like you don't have an inbox to reply to or prescriptions to fill.
Right. I don't do outpatient care. That
Yeah.
is correct. Yes.
Yeah, and I feel like that's kind of been one of the benefits of being a hospitalist as well is, I think your time can be your time off. I think sometimes, non-clinical duties, sneak into that. I think you and I both kind of read the time we're not paid for in this, in this job and in this profession.
Yes. I think ideally, if you're a hospitalist, whether you're a hospitalist medicine doctor or a hospitalist specialist, like I am, ideally when you leave the hospital, you don't have work, but that's
Right.
just not how it works. I mean, we all care about our patients. We want to follow up. We want to make sure that
Yeah.
they're taken care of. So
Yeah. I think it's been interesting for me having, kind of reconnected with some of the primary care colleagues that we have. Like, I've never really had an appreciation for just how much they're doing, the entire time as well.
yeah. But on that note, I think it's important whether you're inpatient or outpatient to really take the breaks, to like
Yeah.
truly, truly, truly take the breaks. I'm pretty much off the grid. I still use my phone for
Yeah.
photographs, but I
Yeah.
found
But I don't think our primary care colleagues can do that, right? So if you've got, and I think that's, we won't stray too much into this topic because obviously I'm very curious to know, but I think like that's the problem, right? Like how do you not answer that obligation when you have an inbox that you have to, refill meds and, a system that is inefficient? And, I think, we're both in a position right now where we get that luxury of time is off. And I think we have to reach out to a primary care colleague. Let's make that guest number 2 because guest number 1 is still a secret, but
yes.
we'll make that guest number 2 because
I think, I would love to
so
hear. I'm sure that it's much more intense for them right now too, just because
totally.
things are changing so much and there's just a lot of non-medical. I think that's the part that I can't involve myself with, is the non-medical bureaucratic red tape that is medicine that wasn't like this when we first started.
Yeah, like a prior auth, or like would that be an
Right.
example?
I want to use my gifts and not for patient care and not use them for waste my time on other things, essentially,
Yeah, yeah. I also attribute this to there's benefits to the electronic health record, but part of it is completely separate physicians from the bedside, and the amount of volume of things that we now have to do at a computer.
I think we
keep
were talking
thinking,
about this, though. We were talking about how when I was an intern, and so obviously when you were an intern, because you were ahead of me, I had paper notes and
Hmm.
I was writing notes on paper in the CCU.
Right.
And how, even though we have EMR, when I do an infectious disease consult, I write it out still.
Right. Right. Yeah. Yeah.
And we talked about how the writing out process is part of the gift and the thinking and the cognition that is necessary to decode and
Right.
diagnose and kind of figure out what's going on with the patient.
Right, right. Yeah, and I think that's like key. When I was still in academic medicine, and certainly having trained in Ireland with a little bit of a different background, but it's what you do in ID, because I think the two are very aligned, is, the data that we gather through the oral history informs everything we know to do next. Like the historical process of, I use a sequence of questions to start to rule in and to rule out what could be going on. And if I do that process appropriately, this statistic I knew in medical school was at 80% of the times I should have the diagnosis. And that drives, and that writing for me was part of the concrete thought process. And I'm so old school and I get teased about this, but I still write out every lab every day. But I can
Mhm.
tell you all the patients I just had, I could probably guess pretty close to every single one of them what their lowest potassium was or their initial hemoglobin and then what it dropped to. Yeah. So I think that's fascinating. And I think we chatted a little bit. I think there's good things for AI, and this is obviously a big can of worms, but the challenge I have is when I've experimented a little bit with condense this into a discharge summary or, write a progress note based off of this conversation. There are things that are incredibly important to me in the way that I've been trained in my thought process that AI screens out. And it's shocking to me because a lot of that are very pertinent questions or information that helped me to make important decisions or to also document that I thought about X, Y, and Z, but I asked a series of questions that had screened it out. So, from a medical legal perspective as well, it's dropping information that is really important for me to demonstrate that I've done a thorough job.
Yeah, and I think I mean, I have faith that AI and humans will figure out a good path forward and that it will be synergistic instead of antagonistic.
Yeah,
And I think AI will play a big role in changing the shape of medical education moving forward. But
yeah,
we're in a transition right now. So I think we're the guinea pigs, and the AI bubble is happening so quickly, and
yeah,
we don't really know yet how it's going to pan out.
totally.
I think that AI has a lot of uses in our work, but also the old school way of just talking to your patients and writing it down. I'm not going
Yeah,
to give that up. That's
exactly. Yeah,
actually part of for the consult for me, and there
yeah,
is some value, and there have been studies done on hand mind, like when you're writing and
totally.
how your brain functions when you're writing with a paper and pen versus with the computer. I think that both techniques are important, and I'm just not willing
Yeah,
to give up the pen yet.
yeah, yeah. Same. It was always fascinating to me to watch, yeah, like the residents start their note in the computer. And yeah, for me, and I've done it. In fact, I can tell you, I think we had mentioned when I did an infectious disease rotation at the Cleveland Clinic, Wendy Armstrong, who now I think is she's really high up in IDSA leadership. She was my attending, and I remember like watching her note taking system on index cards in this structured manner. And to me, that was part of that's like part of the checklist manifesto, right? You keep data in such a consistent manner that the minute I'm talking to a patient and maybe I think, oh, make a note to myself that I need to do this as part of their treatment, it gets jotted down right then and there without me also breaking that visual sequence of engaging with the patient. Right.
Right.
So I think that's kind of the other thing is, I'm writing on a piece of paper and, thankfully I can interpret my own hieroglyphics, but I can maybe think like, oh, I'm chatting with them. I'm like, oh, CTX, ceftriaxone. But it doesn't disrupt the flow of the conversation.
And I think that you nailed it. I think what will be helpful with AI in the future is doctors will not be facing their computers anymore.
All
They'll
right.
again return to facing the patients. And
Yeah.
maybe AI will just capture the nitty-gritty, and then you can kind of doctor the note based on your own hand notes. I don't know.
Yeah. Yeah.
I think that there will be benefits, but we just haven't Maybe some people have figured it out, but I haven't
Yeah,
yet.
no, for sure. Although maybe it's people who have less OCD than us.
Yeah, I know. I think we're very thorough, and the
Right.
answer is often in the history.
Yeah.
So I don't want anyone to disturb the process
All
in
right.
the
Well,
patient forward process that we tend
totally.
to focus
Yeah,
on.
yeah. So you were talking, and I've just keep laughing about what we shared last week when we were both working, and but part of this is the language, right? And this is kind of something that's hit me in a couple conversations recently, is the language of medicine and the power of diagnosis. And so the soapbox that pisses me off, pun intended, which I'm sure, you're in the know about, is this urinalysis, right? And so the story is that you know, we've gone into such a diagnostic manifesto that we do nothing in medicine without a diagnosis, that I'm on this tirade or warpath, of using proper terminology. And so forever I call it asymptomatic bacteria and explain why it's not a urinalysis. And this is important because we're mistreating and mislabeling. And when someone gets admitted to my service and they think that it's actually because of a urine infection, but in reality, the urine has nothing to do with their presenting condition. You don't get pneumonia and a urine infection at the same time. And so we continue, I think, to confuse patients by mislabeling, misidentifying, and not being very cautious with our words. Actually, and let me stop that tangent. Explain asymptomatic bacteria, because you and I shared a bunch of laughs last week about this. But, from an infectious disease doctor standpoint.
Well, I'm into microbes, and I often speak about how they live on us and in us, the various different microbes, and that we have basically like colonies of microorganisms in us and on
Right,
us. So, one thing that continues to happen is little old grandma comes to the hospital and she's dehydrated or confused, and a urine sample is sent, and lo and behold, there's bacteria in there, and so she gets a diagnosis of urinary tract infection. But I think it's important to note that a lot of us are colonized with bacteria in our urine, which means bacteria just hang out there and live there, and they don't cause disease. They have the potential to cause disease and become pathogenic, but
right,
they aren't necessarily causing disease. And I think the important thing to notice now is the bug that used to be really scary in the past was MRSA, and now a lot of people are colonized with MRSA on their
right.
skin or in their nasal passageways. But what we're hearing about now is ESBL, or extended spectrum
Mm-hmm.
beta lactamase. And a lot of people are colonized with ESBL in the urine now, even without antibiotic exposure. They're just de novo, their own colonies of microorganisms have become resistant
Right.
for a variety of reasons that would require a whole podcast, probably. I think I think that it's low hanging fruit for me to try and get hospital and clinic providers and physicians and clinicians to understand asymptomatic bacteriuria, because it's
Right.
too complex. Or I don't know if it's complex, but it's too hard.
Right.
It's too hard because when you have like an objective lab data that shows bacteria, it's hard for people to know that it might not be the cause of the fever.
Right.
And there might be
Right.
other
No.
things to look for. So it is
For
kind of like premature closure is
yeah,
really
yeah.
something you see a lot with asymptomatic bacteria, which premature closure is just fancy for you're not casting your net wide enough.
Right. No, absolutely. And I think that's great too. And I think that's for me is, when somebody then does come to my service, I ask the clinical questions that would make the diagnosis relevant, right? And I like to joke, just because you can pee doesn't mean we should check a specimen. There needs to be reason. But and I think so. The other things I've heard. So I was actually having lunch with a friend yesterday, and two conversations were actually going on. I was not in a healthcare setting, but I think this just speaks to the state of the world. Behind me was a conversation going on where a woman was speaking about a family member who had heart failure. Number one, I hate the term and always work to explain, that this should be called heart efficiency. When I listened to her explain why her family member had heart failure to somebody else, and all both kind of very non-medical. It just reinforces the poor communication and the downstream impacts, because even I was having a tough time understanding what was going on as a physician who this is, largely my bread and butter. And then, the other one for me as well is acute renal failure, or there's these terms that we don't really explain well, and it totally changes people's perception of how their loved one's doing, how they're doing.
I think that's a good point. The semantics or the language of medicine was created by, I don't know, a small group of people, perhaps. And so I think it limits our understanding of the conditions somehow. Even
Yeah,
even those of us who are more open-minded or more broadly educated outside of the system, we still
totally.
are limited by the DSM diagnostic
Yeah,
criteria. And actually the one thing there's a cardinal right there. So beautiful.
yeah.
Hey.
Hello, Nessa. Hello, here.
Sorry, I'm so distracted. It's literally just came to say hi. So I think the one thing that comes up a lot for me is some of the terms haven't been created yet. So
Hmm.
some of the things that people are experiencing haven't been created yet. And some of the terms that we have are either very negative, pathologic,
Yeah.
limiting, and not very descriptive of what is happening per se.
Yeah. No, yeah. No, I think that's a good point, and that makes me think. I don't know if it was the Kevin MD blog or where I came across it, but it was a pediatrician mom who actually wrote a very poignant article about the challenges of reading her own child's medical chart because of the complexity of the semantics and the terms, and not seeing, kind of the forest through the trees. And I think that's, where we've entered to bring this full circle, back when that chart was paper,
Mm.
only the pertinent details got carried forward, and I think also, patients had a better appreciation because they knew that they were the source of truth. And now I don't know what the source of truth is for one's healthcare. Is it the patient? Is it their five EHRs? Is it who? So
No,
anyways,
that's also a good point. That the topic of patients having access to the records is a whole other topic, and how it plays out in healthcare delivery and what
totally.
choices are made and influences our decisions. And I mean, on
Yeah,
one hand, I think it's very empowering. I think they have the right access medical records. We have the right to
100%.
access medical records as patients. And but yeah, on the other hand, there's so much information that's distorted, and so
Yeah,
it becomes hard to work with all
yeah,
these moving objects. But I do think it's going to be more collaborative in the future.
yeah. Yeah,
I do. I think it's going to be less of a higher. We always bring this up. I bring it up every time we talk. Less of a competition or I'm the doctor. I know best what you
totally.
need, and more, what's your story? What
Yeah,
information have you gathered? What can I contribute based on my experience as a doctor and as a person? And
all right.
what can we come up with as the best next steps together?
Yeah, yeah,
I think that's I mean, we do that anyway, but I just hope
yeah.
it becomes more widespread and less the expert knows best.
Yeah, no, smiling, just also fondly thinking that every time I hear myself say out loud, what's up with that, to a patient on rounds, for me, that's my favorite question that forces open-ended question. And we all know where that came from.
Brendan Kelly, yes, yeah, who was our mentor, who unfortunately passed away and transitioned way too young. But
Way
we
too
still
young.
have his voice in our head for a lot of things. What would Brendan Kelly do?
WWBKD, yeah. So for our viewers, so Brendan Kelly was beyond life size, amazing physician, gifted human being, was our assistant program director, associate assistant program director, and for some of us was our third or fourth parent and role model. And for me, I think I've wrote about this once in a blog, modeled that it is okay to be human at the bedside, to laugh to, sometimes some of my vocabulary words may not always be the most choice. And I have flashbacks to Brendan Kelly over my shoulder being like, all right, cool. You're connecting, so yeah, that's
And
my
not
thought.
only is it okay, just it is imperative to
Yeah,
be
for
human at
sure.
the bedside. and
Yeah,
and luckily, I think we have a lot of teachers, some that are past and some that are still here, and they influence us, and hopefully that continues and we can
yeah,
influence other youngins. But yeah, I think
absolutely.
being human, showing your vulnerability, showing that you don't have all the answers, because we don't have all the answers
Totally.
often. And how do we navigate not having the answers together?
Yeah,
I think doctors are, at least our training, I don't know about all of them, are in a unique position because we are comfortable with uncertainty, and
yeah,
that allows us to be uncomfortable with uncertainty on a global scale.
right.
Just what do we have? What's the information? How do we
Yeah,
weed through it? What can we do to move through this moment?
right, right. And I think for us, one of the things I wondered if I saw shifting in medical education was, more for us, we knew how to think the path forward and bring that, that skill set from within. So we're losing you. So, anyways, well,
Sorry, I got
all
this
right.
blue cardinal is, or I don't know if it's a cardinal, but it's just hanging out here and I'm really distracted.
I love it. I love it.
But
No, and
that's
I
what
actually
happens.
were,
That's what happens when you're in nature.
I love it. I love
It's
it.
so
So
beautiful. It's got blue feathers and like a cardinal mohawk. I'm gonna have to look
that's
that bird up. Speaking of birding,
amazing. Right.
um,
Yeah. Well, no,
I
or not birding. So,
I have
well,
my
very
birds
good.
of
Well,
California.
yeah, awesome. Well, we're gonna wrap up. It's been great. So are you headed back down the coast? Where do the next couple of days take you?
I think I'm gonna head, yes, down soon again, not till tomorrow. But I do
Awesome.
want to share some important objects that I always have with me when I'm solo hiking,
Let's do it.
for in case anyone wants to model. But this is a InReach Garmin, I don't know, it's called InReach Explorer. And so if you don't have any phone service, you can still text someone using this. And there's an SOS button. And so it's very much recommended, even if you're not solo and you're
Right.
going to places where there's no phone service in case anything happens, you twist your ankle. I recommend it to everyone. I know the holidays are coming up, so if you know anyone that goes off the grid or hikes, or even if they're not off the grid, I
Yeah.
think you can get one. Even they have a smaller one, like a mini. That would be great. You just have to pay like $11 a month to have this service.
Nice.
And then one thing I'm drinking right now is an electrolyte drink mix because I did a few hikes this morning. And so I'm hydrating. My journal,
Love it.
sunscreen, a protein bar.
Love it.
I have my to go meds, which is just like ibuprofen or vitamin I, my allergy pills, which I always need, and then ODT Zofran or
All right.
Ondansetron for nausea because I get motion sick a lot. And yeah, and then I have my Meditations of John Muir here,
Awesome. Awesome.
which has a bunch of amazing little clip quotes of his,
Love
short
it.
quotes of his.
All right, there we go. Being safe in nature with Nessa. And by the way, none of these are actual product endorsements because we do this by ourselves for fun without any need for this to do anything other than create a fun space for people to join us. So awesome. Well, thanks for following along. Send us thoughts, feedback, questions. I think we will now work on our second guest. Our first guest, I actually did reach out to yesterday and hammering down a time. We've got a fantastic outpatient pediatrician. We have a med-peds primary care colleague as well. And I think we should really get some of our primary care colleagues, who are really keeping the system afloat on here at some point so people can understand what their days are like. So, all right, Nessa, safe travel. Chat soon. Send me I actually have not gotten, well, I mean, we're texting, but don't Garmin messages me. I'll shoot you one to make sure it's still working. So,
Okay, that sounds
uh,
good.
all right.
Take care.
Awesome.
Talk
All
soon.
right, take it.
Bye.
Bye.
All right, now, that's a wrap for today's show. You can find us at www.whatthehellth.org or on Spotify or Apple Podcasts, and like and subscribe to our show. Remember, this podcast's for information and entertainment only, not medical advice. The views you heard are ours alone, not our employers. Y'all take care now and stay healthy out there.